Oh, good morning. This is Dr. McDaniel. It's Sunday the 26th. Hope everyone's having a great day. It's really nice and sunny. It's pretty warm here in New Jersey. I'm at home. I'm still recovering from the wisdom tooth, so I'm swollen a bit. And as the title mentioned, I'm going to continue speaking on preterm delivery. Oui, qu'est-ce qu'il y a? Elle doit t'aider avec les vaisselles. Un peu s'ils sont trop mouillés. Ok, allez, travaille ensemble. Sorry, that's my daughter. I speak French with the children, and they have to do some chores this morning. They do chores on the weekends and a couple times during the week. It's good for their constitution. So I'm speaking about preterm delivery, really. A lot of people can have preterm labor, but it can be arrested and then they won't deliver before 37 weeks. So I'll try to give a quick recap. The recap is that preterm delivery is any birth before 37 weeks. So 36 weeks and 6 days or under is preterm delivery. Late preterm is 34 to 37 weeks. Early preterm is 28 to 34 weeks, and extremely preterm is under 28 weeks. We can still go and get abortions if someone doesn't want their child at 25.5 weeks. In most of our states, a couple of the states, it's even later. So as you can see, 28 weeks is extremely premature because 25 weeks is considered non-viable. There are a lot of inherent risk and morbidity factors, and the outcome is extremely poor. Screening method, well, risk factors we know are the usual and the general. So smoking, excessive alcohol intake, poor nutrition, and then having had a previous delivery prematurely. In addition to that would be cervical and vaginal problems such as anomalies, birth defects, previous multiple surgeries of the cervix to weaken it or allow it to be less strong, so less competent, insufficient. Uterine anomalies where the uterus is smaller or the capacity to contain the pregnancy is less. Multiple gestation, so twin, triplets, or higher order pregnancies. Infection and placental problems. So those are, and of course, chronic illnesses such as hypertension or for some people diabetes. So those are all risk factors. Quoi? Ok. Il y aura des conséquences. Let's see, so those are the definition, the risk factors, the ways that we screen. I mentioned the other day, and one can go back to the previous episodes where I had more detail and I wasn't interrupted so many times. So the monitoring is ultrasound, sonogram at 14 weeks to see if the cervix looks like it's getting shorter or if it's starting to open. We call that funneling. Under 1 inch or 25 millimeters is considered a shortened cervix. 18 to 20 millimeters is extremely shortened and does increase the risk that there will be a preterm delivery imminent. One can also do a swab to check for the protein. Fetal fibronectin protein. That's basically the glue that holds the amniotic sac to the uterine wall. If one sees evidence of that glue, that indicates that that delivery is most likely to occur within 7 days of the testing. If one does not see that fetal fibronectin present, then that indicates that delivery should not occur within the following 2 weeks. Another test that we use to monitor or to screen if there's anything going on is a tachometer. So that's a machine that measures if there are contractions of the uterus and if those contractions are strong. So 20 millimeters of mercury or stronger are moderate contractions. 50 or 60 millimeters of mercury or stronger are strong contractions, and given time can induce delivery. Given time and consistency can induce delivery. So the tachometer is what we usually place. It's a belt you place on the belly with a machine to monitor the frequency of the contractions and the strength of the contractions. If they're strong, which is around 50 or more, and they're regular, they will usually induce cervical dilatation or opening of the cervix and delivery at some point, and delivery at an earlier point than a full-term pregnancy because the baby is obviously a lot smaller. So the ultrasound for the cervical length and opening, and the monitoring for the fetal fibronectin protein, and the tachometer for frequency and strength of contractions is done to give us an indication that that person really is in preterm labor and can potentially have a preterm delivery. Now, if we see that someone has dilatation of the cervix, but we don't see any contractions, then we can simply put them on bed rest, try to decrease the pressure that is occurring on the cervix to help open it as the pregnancy gets further along, and obviously as it gets further along, it gets heavier. They can go on bed rest or even a partial bed rest where they're off of their feet a lot, but they're using the restroom, they're going to the kitchen to get something to eat, but then when they're not using the restroom, they're not eating something, they're in bed with their feet up. Or a full bed rest if you see evidence of definite cervical opening or dilatation, especially if there's contractions accompanied with that, then it would be a full bed rest where they'd have to wear stockings to keep the blood circulating better in their legs since they're not walking, compression stockings or compression device, and then also they'd have to have basically a maid service, someone to feed them, and then a bedpan to use because they really can't put pressure on the cervix. They have to stay still. What we will also often do is give steroid injection, so corticosteroid, to help increase or to help speed up the maturity of the lungs, because the lungs, the brain, and the GI anatomy, so the liver and the intestines, they develop late in the pregnancy, so they usually don't fully develop until after the third trimester, until after 33, 34 weeks. So steroids will help speed up the development, especially the lung maturity, so that they don't have chronic lung disease, and obviously so that they can survive first off, and they don't necessarily have to go on a breathing machine, and so that they have decreased risk of lung disease. So steroids are usually given 1 round of steroids if the pregnancy is under 34 weeks. And if the pregnancy is over 34 weeks, usually steroids are not given, but the amniotic fluid is tested to see if there is lung maturity. Sometimes there will actually be adequate lung maturity, and then the pregnancy can be allowed to go ahead and deliver early because the biggest hurdle, which is the lung maturity, has been overcome. If there isn't lung maturity, then steroids can potentially be given to help speed it up, and then the lungs, another amniocentesis can be done a week later to evaluate for lung maturity. In order to try to stop the contractions, a lot of women will receive a medicine we give for asthma, which is terbutaline. I'll go into the management and the treatment and then some of the outcomes tomorrow, which is Monday, Memorial Day. That's been a recap, and then additional information on the monitoring and the treatment for preterm delivery. And this was in response to a viewer question about potentially shedding some light on why her daughter had 3 preterm deliveries and 3 babies pass away. So I don't know the details. That was all that was given to me. I hope it's been helpful and given additional information and potentially explanation so far. I think I'll finish up tomorrow on Monday with the preterm delivery, and then Tuesday we'll have a different topic. If anyone has questions or suggestions for topics, please submit them here on the Facebook. I also have the YouTube channel, which is GYN Corner. Like, subscribe, and comment on the YouTube channel, GYN Corner. And I hope everyone has a great rest of the Sunday. It's really early. Well, it's not really early, but it's fairly early here Sunday, and it feels like it's around 75 degrees already. So it looks like we're going to have a really nice day. Hope that's the same for everyone. Thank you, and have a good rest of the weekend.